Hi all, I'm Dr. Malati, working as a professor in M College of Nursing. So in this video, I'm going to discuss about the forceps. The objectives are introduction, definition, description of term forceps, types of obstetric forceps, long curved forceps, short curved forceps, classification according to level of fetal head, indications, prerequisites, procedure, complication, failed forceps, summary and conclusion. Introduction. Forceps delivery is a type of assisted vaginal delivery in which a specialized obstetric instrument called forceps. It is used to help deliver the baby during the second stage of labor. It is performed when labor is prolonged or when there is a risk to the mother or fetus. The procedure is done usually by the skilled obstetrician under strict condition to ensure the safety of both mother and baby. Forceps delivery definition. Forceps delivery is a kind of an instrumental delivery, which means extracting the fetus with the aid of obstetric forceps when it is advisable or impossible for the mother to complete the delivery by her own efforts. Description of term forceps. F stands for favorable head position and station. O stands for open cervical arch. That means the cervix must be fully dilated. R, ruptured membranes. C stands for contraction must be present, which means uterus must be contracting and relaxing mode. E stands for engaged fetal head. P stands for pelvis should be in an appropriate size, and S stands for stirrups and the mother should be in a lithotomy position. These are the parts of long curved obstetric forceps. So the parts are handles, lock, finger guards, shank, and we have two curves, pelvic curve and cephalic curve. So these are the parts of the long curved obstetric forceps. Types of forceps, obstetric forceps which we are using currently. Long curved forceps with or without axis traction device, short curved forceps, keel and forceps. These are the three types of obstetric forceps. Long curved forceps. It is relatively heavy and it is about 37 centimeter long. It is lighter and slightly shorter also. It is quite suited for small pelvis and also for the small baby. Forceps measurement length is 37 centimeter. Distance between the tip of the forceps is 2.5 centimeter and the widest diameter between the blade is 9 centimeter. Blades are named left and right in relation to the maternal pelvis in which they lie when we apply. Blades. So blades, it has two curves. I have told you earlier, we have a pelvic curve and cephalic curve. Pelvic curve is designed to fit the curve on the axis of the birth canal. We will call it as a curve of Caras. The front of the forceps is the concave side of the pelvic curve. The cephalic curve on the flat surface, which then articulated, we can able to grasp the fetal head without any compression. Next part is shank and lock. Shank, it is the part between the blade and the lock and usually measures 6.25 centimeter. It increases the length of the instrument and thereby facilitates locking of the blades outside the vulva. When the blades are articulated, the shanks are not opposed together. Next is lock. The commonest method of articulation consists of a socket system located on the shank at its junction with the handle. Next part is handle and axis traction device. Handle. The handle were opposed when the blades are articulated. It measures 12.5 centimeter, that is 5 inches. A screw is also attached, usually at the end of one blade, commonly in the left side, to keep the blades in position. Then coming on to the axis traction device, it can be applied with advantages in mid forceps operation, especially during the manual rotation of the head. So it provides the traction in the correct axis of the pelvic curve and less force is necessary to deliver the head. So it consists of traction rods and traction handle. Coming on to the short curved forceps, which is nothing but the Wrigley's forceps. This is an instrument. It is very lighter, shorter and stubby handled. So it is short due to the reduction in the length of the shanks and handles. It has marked cephalic curve with the slight pelvic curve. So this instrument is used for very low forceps deliveries, for after coming head of the breech delivery, or we can use it during the cesarean section. This is the image of the Wrigley's forceps. Next is Keelan's forceps. Keelan's forceps is a long, almost straight obstetric forceps without any axis traction device. It has a sliding lock also. It is used when the head is in the occipitolateral or occipito-posterior position. After the blades are applied, the head is rotated to the occipito-anterior position. It facilitates grasping, correction of the head because of this sliding lock. This is the image of the Keelan's forceps. Next, coming on to the classification according to the level of fetal head. First is high forceps operation. So here the application of forces on the fetal head can be applied when the fetal head, which means where the biparietal diameter has not yet passed the pelvic brim, which is not engaged. If the fetal head is not engaged, we can apply this high forceps operation. And here cesarean section is preferred to this type of forceps application. Next one is mid forceps operation. It refers to the application of the forceps when the fetal head, that is biparietal diameter, has passed the brim of the pelvis but not past the level of the ischial spine. So during this time we can apply mid forceps operation. Next is low forceps operation. Here it refers to the application of the forceps where the biparietal diameter has passed the level of the ischial spine. And the next one is outlet forceps. The forceps are applied on the fetal head lying on the perineum and is visible at the introitus in between the contractions. So here the sagittal suture should lie in the anteroposterior diameter of the outlet. Indications for forceps operation. If there is a delay in the second stage due to uterine inertia, and if the head is on the perineum for 20 to 30 minutes without any progress, means we can go for this forceps application. So the maternal indications are maternal distress, preeclampsia, eclampsia, VBAC, which is nothing but vaginal birth after cesarean section, heart disease for the mother, failure to bear down during the second stage of labor due to regional blocks, paraplegia or any psychiatric disturbances. Coming on to the fetal indication, appearance of fetal distress in the second stage, cord prolapse after coming head of breech, low birth weight babies, post maturity. So these are the maternal and fetal indication for forceps application. Prerequisites for forceps delivery. Here the cervix should be fully dilated and also it should be effaced. membrane should be ruptured. Presentation and position should be suitable to apply the blades correctly to the sides of the head. The head must be engaged with no parts of the head palpable abdominally, no appreciable cephalopelvic disproportion. The bladder must be emptied for the mother. Presence of good uterine contractions as a safeguard to PPH. So these are the prerequisites we have to check before we apply the forceps delivery. Preparation of the women before we start forceps application. First and foremost is explain the procedure to the mother and should administer the adequate as well as the appropriate analgesia. Place the mother in the lithotomy position and the women should be tilted towards the left at an angle of 15 degrees by the use of pillow under the mattress to prevent this aorta cavern occlusion. Then we have to preparation must also be done for the baby, including equipment for resuscitation immediately after the birth. Procedure. The women's vulva area should be thoroughly cleaned and it should be draped with sterile towels using the aseptic technique. As I told you earlier, the bladder should be emptied. Next, vaginal examination should be performed by the obstetrician to confirm the station of the fetal head and position of the fetal head. The pudendal block supplemented by perineal and labial infiltration can be done with 1% lignocaine hydrochloride to produce the effective local anesthesia. After the pudendal block, we can proceed with episiotomy prior to the introduction of the blades or during the traction when the perineum becomes bulged and thinned out by the advanced head. The forceps are identified left or right and also should be assembled them briefly before we are proceeding with the procedure. The left blade is passed gently between the perineum and the fetal head with the first two fingers of operator's right hand lying along the side of the fetal head in order to protecting the maternal tissue. The tip of the forceps blade slides lightly over the head into the hollow of the sacrum and then wander to the left side of the pelvis where it should sit along the side of the head. The procedure is repeated with the right blade until it sits on the right of the pelvis. It should then be easy to lock the two blades, then should be little or no gap between the handles. A significant gap suggests the forceps are wrongly positioned. Then, if there is a gap in between the forceps means it should be reapplied after carefully checking the position of the head. So, during the application stage of the forceps, the women should be given a full support and attention by the midwife. Meanwhile, we have to check the fetal heart rate throughout the procedure. As soon as the operator is ready and the uterus contracts, the woman is encouraged to push and also to supplement her efforts, the obstetrician exerts steady downward traction on the forceps. Thereafter, the traction is released between the contractions. Next, intermittent traction is continued in the downward and backward direction until the head comes to the perineum. So the pull is then directed horizontally straight towards the operator until the head is almost round. The direction of pull, it should be gradually changed towards the mother's abdomen to deliver the head by extension. Then the blades are removed one after the other, the right one first. Following the birth of the head, usual procedures are to be followed as in the normal delivery. Then IV methogen 0.2 milligram has to be administered with the delivery of the anterior shoulder. Then episiotomy is to be repaired as quickly as possible and the women should make comfortable. Coming on to the complications of this forceps delivery, maternal complications are vaginal, cervical and perineal laceration, episiotomy extension, sometimes PPH, shock and sepsis. And some of the late complications are chronic low backache, genital prolapse for the mothers. Fetal complications are fetal marks, means forceps marks will be there in the fetal phase, facial nerve injury, ocular trauma, cephalohematoma, intracranial hemorrhage, fracture of skull, asphyxia. So these are the fetal complications due to forceps application. Failed forceps. So failed forceps, which is nothing but failure in the operative delivery, may be due to improper application or failure of descent of the head even with forcible contractions. The causes for this failed forceps are incompletely dilated cervix, unrotated occipito-posterior position, undiagnosed bro or hydrocephalus, constriction ring, large baby with the shoulders impacted at the brim. The management for this failed forceps are assess the effect of the mother and the fetus, start the IV infusion with 5% dextrose and also start parenteral antibiotic, exclude the rupture of uterus and plan for other modes of delivery. The women should be shifted to the acute hospital in an emergency. Summary: forceps delivery is an assisted vaginal delivery in which obstetric forceps are applied to the fetal head to help deliver the baby during the second stage of labor. It is indicated in case of prolonged second stage, fetal distress, or maternal exhaustion. The procedure is done only when prerequisites such as full cervical dilatation, ruptured membranes, engaged head, and known fetal positions are confirmed. Here, we nurses plays a vital role in preparation, monitoring, assisting during the procedure, and post-delivery care. Conclusion: forceps delivery is a valuable obstetric intervention when used under proper indications and by the skilled professionals. With correct technique and careful nursing care, it helps to achieve safe maternal and neonatal outcomes while preventing complications of prolonged labor. Thank you.